Hello, Andrew Kolsky here with Therapy BTS, Therapy Behind the Scenes. Today we're talking OCD, favorite topic of mine, as you all know if you've been watching the channel. Today we have Jennifer Lish, who is a PhD psychologist who works with OCD as well as other um, issues in the field, but she's agreed to talk with us about OCD today and share the treatment process and some interesting stories. So Jennifer, could you introduce yourself to the audience?
Yes, I'm Dr. Jennifer Lish. I'm at the Worcester Center for Cognitive Behavior Therapy in Worcester, Massachusetts.
Great, great. Well, thank you for taking time to join us today. One of the things that I like to do in the beginning as we introduce the guests to the audience is if you could tell us a little bit about your background in terms of what got you interested in mental health in the first place.
I think for most therapists, the truth is that psychopathology or suffering in themselves or their family members got them interested in the mental health field, and that's true for me.
Wonderful, wonderful. So, when you started out, especially with the doctorate degree you have, that means you spent a lot of years in school, which means you had to be committed to it. So when you went in for school to start your degree, did you have any idea what type of practice you wanted to have?
No, I did not. I thought I wanted to help people with mental suffering.
Hmm. Okay. And so obviously at some point in your career, you came across OCD because you had to get started somewhere. So can you give us the benefit of understanding of how that happened, what got you exposed to OCD in the first place, and what's the interest?
So I started out as a researcher and published about 30 papers and did research about panic disorder, depression comorbid with panic attacks, transmission of psychiatric illness within families. And I didn't really encounter the idea of OCD until sometime in the early 2000s when I attended a conference that was really a neuroscience for therapists conference at Mass General Hospital nearby me. And I learned about the very elegant and amazing basic research that is the underpinnings of how exposure and response prevention works for OCD and how exposure works for phobias. And I found that incredibly important because the treatments are extremely effective. Because exposure therapy for what's called a simple phobia or a specific phobia is effective for about 90% of people. And for OCD, the effectiveness is similarly high, maybe between 70 and 90% effectiveness. So that's tremendously exciting. So I committed at that point to learning a great deal and getting competent to do that highly effective treatment.
Mhm. Fantastic. And I definitely want to explore that a little bit further in terms of some details related to that. But before I do that, I have a question for you that I ask pretty much all of my guests who work in the mental health field. And that is, in school, when you were being trained, did you receive any training at all specifically related to OCD?
Absolutely none.
100% so far, everybody, same answer. And that's the scary part.
Yeah, I started graduate school in 1980. I went off for intensive clinical training as part of graduate training in 83. And I got my PhD in '86, and I don't think I had heard anything about OCD that whole time. I heard about OCD a lot later from Michael Janicki, who has unfortunately passed away, and from a long list of people who treat OCD and treat phobias,
Mhm.
including psychologists like Isaac Marks and Edna Foa. I had actually worked down the hall from Edna Foa
Oh,
at the Medical College of Pennsylvania, Women's Medical College, uh, very early on. But I didn't get trained in how to treat OCD by Edna Foa. I got trained by, the intellectual and academic descendants of Edna Foa much later.
right. Wonderful. Well, we have a somewhat similarity there, is that I did not get trained by Edna Foa, but the training that I originally received in OCD treatment was all based upon her work.
Of course.
So, it's a well-known name in the field. She did a wonderful job with all the work she did. Um,
My predominant and most important training was, of course, by the International OCD Foundation. I did a behavior therapy training institute. Actually, I did two of them, one about OCD in general, and then one about OCD in kids.
hmm.
And that was certainly excellent training.
Right, right. Yeah, and that's pretty much the case. Like, like I was saying, it tends to be that the schools, whether they be doctorate programs, master's programs, whatever it may be related to therapy, they just don't get into OCD, and you have to go out on your own afterwards to go and learn.
Yeah.
So, so let's talk exposure therapy for a minute, since you were talking about that.
Well, let me say one result of that is that I have patients who come to me who have been treated by a therapist, a counselor in Massachusetts for a decade or for 5 years, 2 years, who have never even heard of exposure and response prevention, much less received it. And this is particularly sad to me when it is a child or teenager or young adult who's really been suffering and whose functioning has really been compromised. And this is different from physical health care. If you go see your pediatrician or your internist or family practitioner, and you or a family member has certain symptoms, they figure out, oh, that's diabetes, or oh, that's heart disease. And then they either prescribe insulin or heart meds, or they send you to a specialist, an endocrinologist in the case of diabetes, or a cardiologist in the case of heart disease. It should be that way in mental health treatment, that if you go into your doctor's office and describe certain symptoms and he refers you to a mental health therapist, that mental health therapist is competent to say, oh, that's OCD, or that's a phobia. And either that therapist should know how to do exposure and response prevention or exposure therapy, or they should say, you need a subspecialist. I don't know how to do exposure therapy. Let me send you on to so and so. But instead, I see people who've been, kids who've been playing checkers and chatting about their week for 5 years while they've been suffering.
Yeah, and that is very true. And thus one of the reasons that I do this podcast, to try and educate people about how to recognize OCD and the treatments that are available. It's, I see the same thing that you're talking about all the time, in terms of, people have seen a counselor, they've done talk therapy for year after year after year, and nothing seems to get better. And it's because they have OCD, and talk therapy will not cure OCD. I'm sorry. It's the wrong treatment for the wrong reason. The challenge is, because the therapists are not trained in OCD. They aren't even able to recognize it because they've never been told what to look for. And I
Yeah.
think back to my days when I was training in therapy in general, um, early days. As I look back, I had a couple patients who had OCD. I had no idea because I had zero training on it. And then
Hmm.
when I became, aware of it, it's like, oh, wow, okay. And then you can do the work, and you get these amazing results in a relatively short period of time. So
That is for sure. I always tell people on average exposure and response prevention will take 15 or 20 sessions, but that if I'm not seeing some real results after 5 or 6 sessions, I'm going to question whether we should go forward. And so I certainly do have a lot of patients who are substantially way better after 5 or 6 sessions. And then after, 15, 16 sessions, we never want to say they're cured because OCD can relapse, but they are free of symptoms and their functioning is no longer impaired. And so that's very satisfying.
very much so. And that's I'm assuming that's probably one of the reasons why you decided to continue treating OCD, which is my same reason.
Yes, yes, yes.
So, okay, so we're talking about this thing called exposure and response prevention. Um, and why don't we start off, maybe do you have an example maybe of a case or a type of case or something that you can explain to the audience? What is exposure and response prevention? What does it look like? How does it work? Give us some background.
So the first step in doing exposure and response prevention is to decide whether to diagnose obsessive compulsive disorder. And so obsessive compulsive disorder is essentially that you have a thought or a concern, we refer to that as an obsession, that excuse me, something bad, something extremely bad is going to happen. And you either avoid circumstances that could cause that bad event to happen, or you do certain things that we call compulsions or safety behaviors to prevent the bad thing from happening. And there is a good example in daily life of something where a bad thing really could happen and is quite likely, and that is motor vehicle accident. So we all, those of us in the US who drive, which is most of us, we are all at risk every single day of death or severe injury. We could be maimed easily while driving. And we all have enough thought about that potentially happening that we take certain precautions. You buy a car that has a good National Highway Traffic Safety Administration rollover rating. You buy a car that has 10 airbags. You buy a car that has a lap shoulder seatbelt. You put I'm driving grandkids around, so I have a booster seat and a car seat in my vehicle. And so I don't drive 80 miles per hour. I use my turn signals. If a child asked, I have a step grandchild person who's 8 years old. He's a funny boy. And he has actually asked, could he climb on top of the car? Would I drive with him on top of the car? No, I would not. I'm sure he'd love it also if he could sit in the front seat without a car seat. Hell, he'd like to drive. We don't do those things. I don't drink while I'm driving.
Right.
I don't, etc. So we all take precautions every day to reduce the risk of death or severe injury from motor vehicle accident to a reasonable level. So it is normal to be aware that bad things can happen. It's normal to feel anxious about them. It's normal to do certain compulsions to prevent those bad things from happening. And motor vehicle accident is a good example of where we all do that. Some people, unfortunately, are think of certain events as more catastrophic or more likely than they actually are. And those people, unfortunately, take precautions, call them compulsive precautions, and engage in avoidance that can really impair their functioning and wreck their life.
Mhm.
So you would want to do the things we talked about motor vehicle accident, but you wouldn't want to just stay in your apartment or house and never go anywhere in a car, because in most of the US, that would mean you'd have a pretty low quality of life.
Yeah. You know what, and I love that example because I use that same example with my patients. And the way that I describe it to them is when I'm talking about OCD, I say, in life, lots of things are possible. It is possible that an airplane could fall out of the sky and hit me on the head right now. It's possible, but it's not probable. And OCD turns possibility into probability. So it's possible that I could get into a car accident. Absolutely. But OCD says to me, it's probable that I'm going to get into a car accident when I go outside, and thus raising my fear. So that's
Yes,
my little anecdote.
that's absolutely correct.
Okay, so that's a wonderful explanation of what's going on for someone with OCD who is seeking out ERP. And so they come to your office, they tell you they have these concerns. What do you do? How does ERP work?
Well, first you do some psychoeducation, call it, and some, call it cognitive work, which is essentially figuring out what the likelihood is, what the probability is of the event that the person is anxious about, and how bad that event would be, how catastrophic that event would be, and then figuring out what are reasonable precautions to prevent the bad event from happening. And that's a decision that's made collaboratively between me and the patient. And then we start reducing the precautions that the patient is taking that are excessive. And we do that by activities together in the session. And I usually target first the avoidances or compulsions that are limiting the person's life the most, and that they want to get rid of the most.
Mhm.
And also the ones that are frankly easy to treat, because treating something effectively gives the patient confidence to undertake the more difficult stuff. So what the treatment consists of is me and the patient doing activities together in our therapy sessions that are the opposite of what OCD would say to do. We
Mhm.
do that gradually. We do it in a stepwise or what's sometimes called a hierarchical fashion. We don't do stuff that's actually dangerous. We don't do stuff that's actually, that's just really scary. we establish an alliance like in any therapy, and we do it with a lot of humor and playfulness.
Hmm. So I understand what you're saying, but let me ask, do you work with your patients in your office? Do you do teletherapy? How do you actually work with them?
Before the pandemic, I was fully face to face. I was in an office and I was out of the office, out in the backyard, into the basement of the building, into the attic of the building, into the bathrooms, into a park nearby, going to stores nearby. I really used the environment and the community a lot. Um, once the pandemic struck, um, we all had we all avoided and did safety behaviors to prevent death from COVID-19.
Right.
And that got me into a home office from which I do telehealth. And that I acquired a lot of patients who are all over Massachusetts, as well as in New York State and Vermont. So
Right.
now it would be difficult for me to continue treating those patients in an office.
Right.
I had people before the pandemic who were driving an hour and a half because it wasn't possible to find a competent therapist for a child with severe OCD in Western Massachusetts, who accepted health insurance. So I got a lot of people then, but there's a limit. I don't want anybody driving to see me from New York State or from far northern Vermont. So
Yeah.
so now I'm doing activities, and I make use of the computer and the iPhone, and I can go around my own property, and the patient can go around their own property or go into the community.
Hmm.
So we're doing activities, but over screens.
Right. Right. Okay. So let me go back to a couple things there. So you mentioned about COVID and its impact, and I want to get to that in a little bit. But before I get into that, because that's a discussion all in and of itself, before we get into that, so we're talking about just delivering exposure therapy and now telehealth certainly being a big thing that, like you said, brings treatment to people who couldn't physically get to an office before. And I'm finding the
Right.
same thing, people all over the state. I work in Virginia and Florida, so I've got patients all over both states. Um, but so let's take an example of, for example, I have several patients who are afraid of vomiting. Okay. And they've got OCD. So what do you do if you're on a computer with someone like that? How do you do exposure therapy with that type of a patient?
I should have given a trigger warning, but that's that's an example of something I've done a lot. So exactly what you do depends on the individual. And somebody who initially comes in with a concern about vomiting, you want to get more information. And that more information might lead to ideas about disease transmission. And then you would do things that have to do with particular diseases and with the idea of acquiring a disease. Could be just concerns about vomiting. Some people just have a concern about vomiting, and then you do exposures that have to do with vomiting. A lot of people, though, who have emetophobia also have essentially contamination OCD.
Mhm.
So I've done a lot of stuff about eating foods, about eating foods with freshness dates that are gone by. So it depends on the individual, but any exposure, I've yet to figure out an exposure that somebody needed that we could not do together in session. And that's really important to me because, along with all the people who tell me I've had talk therapy for years and never even heard of exposure and response prevention. There are also people who will say, I saw a therapist who knew about exposure and response prevention, and she told me to do it on my own in between sessions, and I just didn't or couldn't, or it was too scary. So to me, therapy means doing exposure and response prevention together in the meeting.
Yeah, yeah, I agree with you. It's funny you raised the point about, eating different foods and all, because that reminded me of a patient that I had where we did exactly that. One of the OCD concerns was about, you're talking about expired food and things.
Yeah,
And for this patient, the food wasn't expired, it was just she had it for a little bit of time.
yeah,
And so we actually, during session, would go to the refrigerator, take out whatever the food was, make sure that it was safe, because if it's expired, number one, it'll say expired. Number two, it'll smell bad. Number three, you'll see mold, those types of things. But
yeah,
totally safe food, but OCD was saying it was unsafe. So we would eat the food as we did our work.
yeah. I had a patient recently who did not have a nut allergy. Absolutely did not. Had never had anaphylaxis or any kind of symptoms in relation to consuming any food at all, but nonetheless was avoiding nuts out of anxiety.
Mhm.
And I have right over here still a box of different nuts that she and I would eat together at the beginning, at the end of each session, and in between the beginning and the end, we were doing other stuff. I had somebody who I called Fruit Girl because she had a long history of running out of the house screaming if her parents cut some fruit, the any fruit, whatever fruit you can think of. Um, and we started, she couldn't eat any fruit. She couldn't tolerate fruit being in the house or being eaten by anybody else. Again, no food allergies whatsoever. And we started out, this was face to face, but you could do it on Zoom too. We started out with scented candles and soaps and just smelling fruit scents. And then we moved on to, I had a coffee table covered with different fruits, and the young woman and I and her mother ate fruit all session. Those were some fun sessions.
Right, right. No, I have one that I'm going to be working with today, a client who has similar types of concerns. And so one of the concerns is if you have like a bag of chips, other people may have put their hand in the bag of chips and now everything is contaminated, right? So of course, what are we going to do? We're going to work up to eating chips out of the bag. So but what do you say to someone who's listening to this podcast and maybe doesn't have a lot of understanding of OCD or OCD treatment, and they're thinking to themselves, "Wow, that's really cruel. You're really stressing them out. That's not good."
I say go talk to a surgeon about how they cut people's bodies with the intent of curing illnesses and problems. And I would say that one of the problems with therapy for OCD is that there are a lot of therapists who are afraid of exposure, who believe it's cruel, and who are afraid to do it. And I would say you need to be cruel to be kind. I would say the best thing I have done for quite a number of people was to eliminate their OCD. And they thanked me. If our situations were reversed, I would be thanking them profusely.
Yeah. Well, this goes back to something we were talking about before, which is you've got someone with OCD who spends 2, 3, 4 years with the therapist talking about things, making no progress, not addressing their OCD at all. To me, that's cruel.
Yeah.
What's effective is to provide evidence-based treatments that solve the problem. So do you have any stories of, I don't know, take a patient concerned about vomiting? Do you have any stories of working with them and how long it took to get past that?
Yes, sure. I treated somebody recently. She's a Clark undergraduate college student, and she was trapped in her dorm room, she'd been unable to go to the bathroom. She was peeing in a jar. She'd been unable to go to the dining hall. She was eating only takeout when she could get it delivered to her dorm room, and she was unable to go to classes. You don't fare very well at a college if you cannot attend classes. She was unable to go to extracurricular activities or parties. She was having no fun. And we met about 4 times, and that enabled her to get out to classes and to the cafeteria and to extracurricular activities. We've continued meeting intermittently about other issues, but the getting her out of being trapped in her dorm room took about 4 sessions. And I'm really delighted the last time I met with her. And yeah, I first worked with her in maybe December. Now it's April. The last time I met with her, the first thing she said when she got on the Zoom was, I don't have any OCD. I don't have any concerns like that to deal with. And we met for just 15 minutes to catch up and make another appointment for 3 months down the road.
Wow. Wow. That's amazing. That's great to hear. So there is hope for if someone is listening to this podcast and they have or believe they have OCD, there's hope when you use proper treatment.
There certainly is. That particular young woman had concerns about vomiting for quite a number of years, but she had been predominantly functioning fine. What happened was somebody threw up outside the dining hall at her college, and she couldn't go to the dining hall and couldn't leave her dorm room after that. So she had an acute problem that was fairly new, and she'd had a longer term concern, and we've eliminated the longer term concern too. Now she can pretend to throw up, no problem.
Wow. Very nice. Very nice to hear that. So let me transition over into something we said we were going to come back to here because it seems
Yeah.
like the right point. We're talking about contamination type OCD and fear of different types of maybe, germs or bacteria or whatever it may be. And then here we go. We get this thing in March of, what was it, 2020, I think it was, called COVID.
Yes.
And everybody with a fear or a concern, or maybe who didn't have it, all of a sudden, everything is, oh my God, I'm going to die. And people really were dying from it. How did that impact your work, and how does it impact what you see today?
It had a huge impact on my work. In a way, if in my local area, it was March 12th, 2020. In a way, a lot of people who, a lot of people acquired behaviors on March 12th, 2020, that would have been considered OCD in preceding months and years of my career or my lifetime, that to me were not OCD, on March 13th, 14th, 15th, 2020. And that is because of reasons that have a lot of importance regarding how you diagnose OCD and how you treat OCD. In March 2020, we didn't know how you caught COVID. We didn't know what the mode of transmission of the disease was. We thought that you might get it from mail that you brought into your house. We thought you might get it from groceries that you brought into your house. A whole lot of people left their mail and their groceries in their garage to age for a few days before bringing them into the house. A whole lot of people washed hand goods in a weak bleach solution in late March 2020. My family had a lot of laughs months later when my offspring went to open a plastic bag full of dried beans and found that the beans had all sprouted and smelled kind of bleachy. It was rational to do those things on March 11th, March 12th, 2020. It was irrational to do them in January of 2020, and it's irrational to do them now because of science, because science learned what the mode of transmission was, what the likelihood of transmission was, how to prevent acquisition of illness by vaccination and by treatments that were not available in March 2020. So behavior that would have been rational to prevent a death of oneself or one's family members in March 2020 would now be again OCD, obsessive compulsive disorder. So I spend a lot of time with people who are concerned about contamination, about disease acquisition, which is often people who have contamination OCD. They're concerned about germs, touching things, and catching diseases. So I spent a whole lot of time talking about HIV and rabies and measles and mumps and polio and COVID and the flu, and working out for each person, although it's, kind of the same for many of us, what the actual risk of illness is, how likely death is, what vaccinations are available, and what precautions other than vaccination are good uses of our time. I spent a lot of time talking about hepatitis and tetanus and really interesting stuff.
Yeah. No, I'm thinking about different conversations that I've had with different patients and all. And earlier we were talking about the car accident example, and I said, with OCD, possibility becomes probability. And that is so true with people who talk about COVID, because you'll have people even today, and it's now it's April of 2024. And
Yep.
like you said, we now know the method of transmission. We know the science. We know that COVID has basically kind of come and gone. Not that it's gone totally, but it's not the way it was at the peak. And we know how to protect ourselves, and there's been variants. We know a lot about it now that we didn't know before. But you'll have clients who come in and say, yeah, but I could get COVID. I mean, I need to stay in my house and be scared because I could get it. And the answer is, it is possible, but it is not probable, because you know how it's transmitted. You take reasonable precautions. The science tells us that it's not, what it was back then, but for all these reasons. And it's still hard for some of them to get past that fear, because they've told themselves the story over and over and over again, that they've built it up to be this monster that's going to just eat them alive. Yeah, are you seeing that too?
Oh, yeah. The human brain does not grasp probability well. Our brains were not designed for 2024 when we have information about what's happening to people all over the planet and get fed information by the newspapers, the TV, the radio about people all over the planet. The human brain was designed for when we were hunter gatherers, you know, and so it grasps well. We lived in communities of maybe 50 people traveling around in a pack. And so if you live in a community of 50 people and someone eats a certain berry and they die, don't eat that berry. If you live on a planet where you're hearing news about 9 billion people and someone eats a berry and dies, you don't need to worry about that berry because it probably doesn't even grow on the continent that you're on anyway.
Right.
And the same with different diseases. And so I treated somebody recently, another female who no longer has these OCD concerns. She was unable to walk around her apartment barefoot because of concern that this was a student living in, you know, typical apartment housing in a city near a college, bunch of students living together, and it's old buildings. And her concern was that she would step on somewhere that a mouse had urinated or defecated. Well, there's no diseases that you can catch from mouse urine or feces in Boston, Massachusetts. There's something called hantavirus that you could catch if you went into a shelter on the Appalachian Trail that had been inhabited by rodents all summer, and you laid down in the bed and breathed in the dust of that. But anyway, so she and I now, wait, so, you know, what did we do in our meetings? Took off our footwear and walked around the floor, and then related stuff like that. We each laid down on our own floor and rolled around. And then we did some other stuff. Anyway.
Yeah. It's as you're talking about the mouse and all that, it brought something to mind for me, which is, um, you know, we're talking about possibility becomes probability. Well, a lot of times the possibility isn't even a possibility. And what I mean by that is I was thinking back to an opossum, and you look
An
at them.
opossum?
Yeah.
Okay.
So you look at them and they look like they could be kind of scary and, dangerous, and, their teeth are kind of, sharp, and they have this weird tail, and they look like they're probably wiry and gross and whatever. And oh my God, I don't want to get bitten by one of those and get rabies. Well, then I started to learn about them, and I have pictures and video of me holding them and everything now. They don't carry rabies. So you can't get rabies from them.
Yeah.
Actually, impossible. So there's
Yeah.
no even possibility, much less a probability.
Yes,
And
yes, yes.
they're actually extremely docile, very soft. And I held one, and all it wanted to do was kind of snuggle into my neck. They are not aggressive at all. So we have these stories that we build up in our mind, but in reality, factually,
Yeah.
they're not even close to being true.
Yeah.
So
Yeah. I treated somebody recently who is actually an engineer, but who believed that if you leave your stove heating elements on for a while, they will get too hot, melt, catch fire, and set the house on fire. Well, that's not true. That's another thing that actually doesn't happen at all, is impossible. And so this person was restricting their lives in a variety of ways, doing a lot of just about to go out to do something fun, play in a bluegrass band, or do something important for their work. go to their job, would have to come back and back into the house, open the oven and stick their hand in to see if it was warm, touch each of the burners, then come back and do it all again and then again. And it was taking them, I think about 45 minutes to leave the house each time they wished to, based on something that was like an opossum carrying rabies, which they don't. And
Yeah.
stoves don't melt and catch on fire.
Right. Yeah, it's interesting, but the reality is, and I don't want to make light of it, because the reality is someone with OCD, it's very real to them. Whether it's factually possible or not, it's still very real to them, and it
It
impacts their
was,
life.
yeah, I don't have OCD, but it was very real to me that there were refrigerator trucks parked outside the apartment that my oldest child was living in New York in March 2020. I drove down there and drove back here in a day to retrieve my adult offspring, because the possibility that they would die from COVID was real at that time. There were morgue trucks, and people were catching it left and right. And my child lived in a communal kind of setting and had friends who were catching it left and right. So there's nothing funny about OCD, and there's nothing funny about being terrified or about limiting your life in order to protect yourself and your loved ones. That's what we do as human beings. But sometimes our brains get a glitch in which something that is, as you say, a possibility starts to seem like a probability, or a glitch in which something that is unpleasant but harmless, such as vomiting, starts to seem like a disaster wrapped in a catastrophe. And then exposure and response prevention can help us to get our brains reset to accurately perceive the likelihood of an event and the catastrophicness, the badness of the event, and to get our behavior reset to fit with that accurate information. And that's what we essentially do. I see a lot of people who can say, I know it's not dangerous, but I do this anyway. And that's why behavior therapy works. Behavior therapy gets people's behavior to be consistent with their intellectual beliefs, and then the emotional brain catches up remarkably quickly.
Yeah. I like the way you describe OCD as sort of coming from some sort of a glitch, because one of the phrases that I use sometimes is, think of OCD as a son of a glitch. It's
A
something
son of a
that comes
glitch. I
from
like that.
glitch.
Great. That's great. Son of a glitch.
So, this has been very educational, and I really appreciate you sharing all of this information. So let me ask you this. If somebody is watching this podcast and they think that maybe they have OCD, or maybe they recognize these behaviors in a family member or a close friend, what is your best advice to someone who is now recognizing that maybe OCD is something they should, be aware of?
My advice is to go to the website of the International Obsessive Compulsive Disorder Foundation and to search on there for a therapist, and to see that person. If there isn't anybody trained by the International OCD Foundation, an alternative organization is the Association of Behavior and Cognitive Therapists, ABCT. Also, Anxiety Depression Association of America, ADAA. So if you see somebody who's listed, also actually the Academy of Cognitive Therapy. So International OCD Foundation, Anxiety Depression Association of America, Oh, there go the balloons. Emojis. Um, Association for Behavior and Cognitive Therapy, or Academy of Cognitive Therapy. It's 99% of the people on those websites are competent to do exposure and response prevention. So my advice is to find a competent, trained psychotherapist through one of those 4 websites.
Yeah, and I agree with you completely. And I do want to add to that, that if you are someone seeking uh, a therapist, a psychologist, someone to help you with OCD, when you talk to them, first off, those are the websites to go to where legitimate people with solid training are going to be listed. But if you talk to someone who says they treat OCD, it is absolutely totally appropriate for you to ask, what training do you have? How many people have you treated? What methodologies do you use to treat OCD? Ask them about their qualifications, because it is unfortunate that I've seen listings of people who say they treat OCD who have no qualifications whatsoever, nor do they have even the basic understanding of what OCD is. It's very easy on some of the websites to check a box and say that you treat everything, and then you just put it out there hoping you're going to get more clients, and you have no business doing that if you don't know what you're doing. So please always ask the question. A competent therapist will be glad that you asked and will be happy to answer. If they're stumbling through the responses, you may want to rethink your choice.
That's why I have all my certificates from my BTTIs, and hung up there. And that's why I have this big bookshelf, and I can pull off it all the right treatment manuals for treating OCD or selective mutism or panic disorder or agoraphobia or oppositional defiant disorder or specific phobia, etc., or insomnia. There are some very specific treatments for specific disorders. It used to be that therapy was the treatment for any mental health condition. That's no longer the way it is. Now there are specific treatments for specific disorders, and a competent mental health professional can give you a diagnosis. They have to be able to build a health insurance company,
Mhm.
and should be able to discuss with a patient or a patient's family members, in the case of children or teenagers, exactly what diagnosis the therapist is making, exactly why, and what the treatments of choice are for those disorders. Just the same as if you had cancer and went to see an oncologist. The person would talk about surgery, talk about chemo, talk about radiation, be able to explain to you which is recommended for your particular condition, and be able to show you published papers about 10-year remission rate, 5-year remission rate for those, for your particular stage and organ type of cancer. It's a scary analogy to use, cancer or diabetes, but it's accurate, because psychology, psychotherapy has gotten to that point of specific treatments that have been shown to be effective by what are called randomized controlled trials. So we're doing evidence-based treatments.
There you go. I'm with you 100% of the way, and that's why I always encourage people, find someone who knows how to treat the thing that you have. You wouldn't come to me for certain types of mental health disorders. You would come to me because I practice OCD. I practice sleep disorders. I practice Tourette's, phobias. That's my specialty, and that's where I have probably hundreds of hours, if not more, of extra training and the field I've written in, those types of things.
Yeah,
But don't come to me for something that I know nothing about, and it would be inappropriate for me to try to treat you because I wouldn't know what I was
absolutely.
doing.
Absolutely correct. Really important to stay within our scope of practice and to know what that is, and act accordingly.
Yeah. So Jennifer, I really appreciate your information and your stories and your time. If somebody wants to get in touch with you, first tell us, where are you licensed to practice and how do they find you?
I'm licensed to practice in New York State, Vermont, Pennsylvania, and Massachusetts. And my website is WorcesterCognitiveBehaviorTherapy.com. So the big challenge is spelling Worcester. We
I was going to
pronounce it,
ask.
yeah. It's like the sauce. It's like Worcestershire sauce. We pronounce it Worcester or Worcester. And so it's, spelled like Worcestershire sauce, WORCESTER. WorcesterCognitiveBehaviorTherapy.com is my website.
Fantastic, fantastic. Well, thank you again for taking the time out of your day to share all of this great information with the audience. If you're a member of the audience and you feel that you may have OCD, or you know someone who might have OCD, or even if you just want more information, the websites that Jennifer shared have great information. The primary one would be iocdf.org because that's their focus is OCD. So check it out, educate yourself, make sure you're talking to qualified professionals because help is not that far away as long as you're talking to someone who knows how to provide it. So thank you for your time, Jennifer. We really appreciate it, and we wish you the best of success in your continued practice.
Thank you very much for your interest and your time. And anybody who's suffering from anything, I wish them well.
Thank you.